We're very fortunate that we've been able to secure not one, but two CQC personnel today, and senior ones at that. They are planning to join us around 1:15. We've had a number of questions sent in to us, which we've passed on to them, and points. Some of them were more polite than others, but I made them all nice before I sent them on to them. If you want to raise a question, but you don't want to raise it directly, then you can either put it in the chat, or you can text it or email it or WhatsApp it to Dudley and myself, and then we will, if you like, anonymize it. I'm seeing that the numbers of participants of today's meeting are growing, which is great, and I would expect there to be quite a lot of people simply because it's CQC and the situation, as we know, at CQC, and they've been frankly pretty honest about what the situation is as far as they're concerned. I think Dudley's already mentioned yesterday's march, and I haven't seen much about that. I hope it was a success. Certainly social care needs all the help it can get. We actually were due to run a face-to-face meeting around sponsored an international recruitment yesterday for South East London, which we postponed. At the moment, I don't have a date or a venue to remake that. The local authority are getting on to tell me, apparently, but most of the presenters, the lawyer and the gangmasters, have expressed a willingness to come to the rebuilt meeting if we can make it a date that works for all of them. So apologies again for that. And anything from you at the moment, Dudley?
I don't know if to be the voice of cheer or doom or gloom. I think the reality of it is that this year, social care and those who are in it, it's not very straightforward. We're all looking for answers, solutions, whether it's your local authority, whether it's your staff, whether it's Home Office, whether it's UKVI. One thing is that it's not necessarily going to be the easiest of years, and we've had lots of providers come and speak to us. I think no matter what, I think you have to take an honest look at your business and yourself and where you were at. But also as well understand that it may not just get bright overnight. So I would say hang in there where possible, but seek advice, professional advice, whether it's via, I know citation is in the room, so I'm not going to just pull them out, but actually keeping on top of what you have to do, your compliance wise, and all the things that are possible, utilize things such as any tech that's possible, be sensible. But most important thing, we are here just to ask, even if you're not sure, you can ask our opinion and we give you advice or point you in the right direction. We may not have all the answers, but the likes of Peter does speak to CQC, and we also speak to local authorities. We also have a raft of professionals that we're in touch with, be it lawyers and so forth. So the key is that social care isn't going to go away. It's just maybe a bit of a rough ride at present. Also as well, you can utilize things such as the WhatsApp groups. There are other fellow colleagues who may have gone through what you've gone through and had different experiences. I know with some of the smaller domiciliary care organizations, some of them are potentially trying to come together as groups. The other side of things, sadly, we will miss you. People have told me they want to sell up as well. So there's also some people are sad leaving. So there's a various things that are going on. And you have to also just keep, if not in touch through us and up to date with what's going on. There's lots of things coming left, right, and center, and to keep up with it is almost quite difficult. But please, where you can, do just things like CQC changes or anything like that. Do keep up to date. Anything else, enjoy the meeting. Please, please, please. One thing I will say is we get CQC in and you have this time where you get to ask questions and then no one seems to ask the questions. And then afterwards, they say to us 101 things afterwards. So if you want, as Peter said, you can use the chat box, or you can send a message to us privately in the chat and we can ask the questions, raise your hands. That's all I would like to add in. Other than that, we'll just add any information in on the chat for some up and coming events. We've got some ongoing things with international recruitment. We've got a mock UK VI inspection that we've got with a lawyer. So for those who have experienced or hadn't experienced it, you'll get to see what it looks and feels like. Slightly different from a normal inspection, but still how to be prepared as well. Outside of that, Peter, I think that's the general roundup. And if anyone wants to share any stories about yesterday, whether they feel it was a success for the march that is in central London, Parliament, if they feel it was a success, or whether they enjoyed it, or dare I say it was a waste of time, but however you felt, it'd be good to see that, because it's social care needs to come together to actually make a difference of what's going on. And that's me in a nutshell, Peter.
Okay, thanks, Dudley. There are a couple of things. Firstly, training funding, LDSS funding. If you aren't accessing that training funding, please do. There's a limited amount of it, and once it's gone, in that sense, it is gone. But it is very useful. If you're struggling to get to grips with it, to get to grips with the portal, then talk to one of the training providers that use it, such as Social Works. John Buttle and his team there will help you through it, and they'll also provide some very useful training. Again, CQC, local authorities are always complaining about the poor quality of training in social care, so there's an opportunity. Dudley and I keep being asked about tendering, writing tenders, producing tenders, helping providers input tenders. What I would say to you, if a tender comes along, make sure it's actually one that you can complete. Read the small print, and please don't be conned into actually applying for a tender that's 50 miles away or 100 miles away because a tender writer is telling you that it's ideal for you. They're simply interested in charging you to write that tender document. And many of them are now produced by AI, or they simply use a template. And so half a dozen people will apply for the tender with the same content. The software that the local authorities use will pick that up and will reject all those tender submissions. So it's simply a waste of money. Applying for tenders, particularly if you don't have a CQC rating or you don't have sufficient turnover, it's absolutely not going to happen for you, particularly in domiciliary care. And we're also seeing with the fee increases that local authorities are asking for very detailed costings, something like Care Cube, etc. Many providers are having to use their accountants to complete these documents. We're also seeing some documents coming out by way of costing requirements that providers cannot complete. For example, if you're I'd say a domiciliary care supplier or a supported living CQC registered supplier, and the local authority is asking you to do some of the costings, you can't do them because those costings are only known to the housing association or the landlord. And you have to make that clear. And sometimes the housing associations are not prepared to complete their part of the document. Again, you have to make that clear. Do make sure that you're making sure that the local authority actually knows what you're doing and how you can get the information to them, because you don't want to lose that. We've seen providers who've lost business because they simply cannot, they do not have access to the figures the local authority is demanding, which is unfair and doesn't work well for the clients, for the service users either. And in a way, the same applies to sponsored recruits. We have put some questions to the Home Office, which we haven't yet had answered. The last update from the Home Office rather was before Christmas, December the 19th. We are expecting that there will be a further update. I would think by the end of March. or into April, we are chasing them for that, and to make sure that we get it. But if you are using sponsored recruits, it's a requirement basically that you keep onto the portal and make sure you're updating yourself with information from the Home Office or from UKVI, because they won't pass it on to you. And if they ask you questions, they expect you to be able to know the answers in that sense. That's pretty much what I've got to cover. As I say, we're expecting CQC to join us around 1:15. So if there are any points or anybody wants to make any points, then ask any questions, please do. Or if any comments, as Dudley has said, about yesterday's march or anything else.
I just quickly put something in the chat. You talked about tenders. I think tenders are something which comes around all year round. I've access to a portal which tells you the latest tenders coming up, for example, the month. So I know lots of people are looking to branch out from just their local authorities or just fed up. So you can let me know and I'll put you in touch with the portal. Worst case scenario, you can look at what's coming up and make a decision. I would still, before you dive in, still think about whether it's right for you. As Peter said, think about your rating, the type of service you have, whether you're based there. There's a few things there, but at least it gives you an idea of what to do. I think a lot of people are struggling in trying to stretch their set of arms and legs into different parts of the world. Potentially, and Peter doesn't know this yet, we may have maybe a session on tenders, tender writing, and all things around tendering, because it's not just about even when you apply for a tender, whether you're right for a tender. Also, as well, a lot of people miss out on actual tenders because they haven't read the small print or have to have certain things in place. We could probably do a whole day on it, a masterclass on it. But so we will come back to you on that one. And I know we get lots of people talking to us about that. So that shouldn't be a problem.
Okay. There's a couple of points popped up in the chat. One is, what is Cube? Care Cube is a costing document that local authorities use. They've used it for things like fair cost of care. And it's a fairly complicated, or it's not a complicated document, it's a thorough document. There's lots of information actually required in there. And I presume the question, what can you explain what the funding is for? I presume that is around the training funding, LDSS. There's a whole raft of funding that is available for training. It's NBQs. There's other training there. I don't have a list here. We do have one, but you can go onto that if you want more information. What I'll do is I will put John Buttle's contact from Social Works, so he can give you all the information you require, or actually just search LDSS. Again, I'll dig the information out and I'll put that in the chat for you during the meeting. Excuse me. Rob, good morning. I see CQC have joined us.
Good morning. How are you? You okay, Peter?
I'm fine, thank you. Yourself?
Yes, I'm fine, thank you. Fine, thanks. I've not joined a Zoom meeting for quite some time, so it's not on my usual background, and I don't know how to do it, so apologies for that.
Yeah, no
You're
problem.
managing well, Rob. Don't worry, you're managing well at the moment.
All
So
right, okay.
if anything happens, we'll let you know. But at the moment, you are live, and you've got an audience going to be waiting on all the things that you've got to tell us. So I'll leave it in your hands.
Lovely. Okay. Well, thank you very much, and apologies from my colleague Jill Hodgson-Riley. So Jill was, as you know, was due to join the meeting with me. I'm Rob Assall. I'm the Network Director for London and East of England here at CQC. And Jill Hodgson-Riley is one of the Deputy Directors for London. But unfortunately, Jill is having to deal with an urgent situation, so it's just me today. So I hope that's okay. So what I thought I would do is just give an update on where we're up to at CQC with some of the developments and to some of the recent challenges that we've had, and then open it to a discussion if that's okay. Does that sound okay, Peter and Dudley?
Have you got any presentation or any slides to put up at all?
I haven't done it as slides. I was just going to do it as a discussion if that's okay.
That's fine. Yep.
Is that okay? So good morning everyone. If I can just give you an update on a lot of the work that we are doing in CQC. We've got Julian Hartley is our relatively new chief executive, and Julian has now been in post for 3 months. And there's been lots of work that Julian has commenced since he started in post. So you will know that we've had a number of issues, particularly with the implementation of the single assessment framework and with our new regulatory platform. That's caused us a number of different issues and problems here at CQC. So we are, Julian has put into place some real robust actions that we need to undertake to resolve these issues. So one of them is, we've got 4 immediate actions. So one of them is looking at the progressing stuck assessments that we have in our system. So these are the inspection assessments that are in the new regulatory platform. So we're looking at what assessments are in there, which ones need to be progressed, which ones need to be priority. And we have seen that the numbers are reducing, but there is still, quite a bit more work to do to continue to improve the system, to get these reports progressed through the system and prevent that happening in the future. But it is a key priority for us. Then another key priority is enabling new assessments. So that's increasing the number of assessments inspections that we do. And for adult social care, we've put in place what we're calling a hybrid approach, and that started on the 2nd of December. And we've streamlined the assessment process, making it easier to complete assessments within our new regulatory platform. And we're looking at a whole number of different areas where we need to make improvements, particularly around the how we're going to be scoring doing and scoring, which will lead to the ratings, to make that less complicated than it currently is. And what we've seen is, since we put in this new approach, we are seeing that the number of assessments is increasing, but we are aware that we do need to significantly increase the number of inspections that we are doing. And that's definitely going to be a focus going forward. It will also take into account, because what we've put in place to enable this hybrid approach, we've put in what we're calling a test and learn team in place, particularly for adult social care. And that's a group of colleagues working on what we can do to streamline processes, make improvements on the system, get the throughput of inspections much quicker. And with that team is doing some excellent work. It's a team across all of our 4 networks, made up of managers and inspectors across the different teams across the country, and they're having a really good impact. But we are very aware that we need to significantly increase the number of inspections, assessments that we do over the coming year. And we're also taking into account, of course, the findings from the Care Provider Alliance review that was completed, and that was published on the 11th of February. And hopefully you've all seen that as well. We can talk about that a bit later on as well. We also need to do more work to look at the how we are processing information and notifications that are coming into CQC, and with the issues that we've had with the new regulatory platform as well. There has been it's unfortunately meant that we've got a backlog of cases and notifications. So we are working through them, and we're seeing as of the 3rd of February. There's been a reduction of 41% of that backlog. So we are working through them, obviously working with the oldest and the higher priority ones first. That's absolutely key to get this sorted out, because we know that it's very much linked to our key role of keeping people safe and protected. So we are doing that. There's another key priority is looking at how we can make improvements to the registration backlog as well. So we are focusing on the applications that are over 10 weeks old, obviously focusing on the oldest ones first. As well, and we are seeing that that we're making a good dent on them as well. So our target is to reduce the backlog of registration applications over 10 weeks to less than 22% by the end of March. And as of the 3rd of February, we were at 35%. We're over 10 weeks old. So again, we are seeing it reduce, but we're being ambitious in terms of what we want to get that reduced to over the coming weeks and months. And then linked to these 4 sort of key immediate actions that we need to do, we've got 5 what we're calling foundational improvements. So, and that is one of the first one is looking at our assessment approach. So this is the need to review our single assessment framework approach. So looking at the framework and methodology, and this will involve internal and external engagement, followed by formal consultation later on this calendar year. And we'll be taking into account the reviews of Professor Mike Richards and Dr. Penny Dash, but also the Care Provider Alliance review as well. So that's key work that we need to be doing as well. And the timescales, including the plans for our interim and longer term approach, will be agreed over the coming weeks. The other thing that we are doing is that when we moved to prepare us for implementing the single assessment framework and the new technology a few years ago, we changed how we done things, which you'll all be very aware of in CQC. So previously we had different directorates. So we had a directorate for adult social care, hospitals, primary and community care, and we moved into one ops directorate and created another directorate called regulatory leadership. And what we're looking to do now, given that things haven't worked out as well as we'd anticipated, we're looking to see how we can work more closely and perhaps become one new directorate combining operations and regulatory leadership. And we've also had agreement that we can recruit for new chief inspectors. So that recruitment is ongoing for all of those chief inspectors. So there'll be one for hospitals, one for mental health, one for adult social care, and one for primary and community care. So the primary community care and the mental health one, those adverts went out at the beginning of the year, and the ones for adult social care and hospitals have gone out this week. So that recruitment is underway, which is great as well. And we're also, when we moved into the new operations group from the previous sector-based directorates, we changed from having sector-based operational managers to more generic managers. And again, that's not worked as well as we anticipated. So we've done pilots and reviews to see whether we need to go back to sector-based working, and that is all being evaluated and reviewed at this current time as well. So there'll be more communication about that coming out soon. We're doing a lot of work, as you would imagine, on our technology and IT systems as well, and we've done an independent review by an external consultant on that as well, called Peter Gill. So that review is currently being considered as well, and we've also going to be appointing a new chief digital and data officer, a woman called Esther Probbins, who's going to be starting working with us next week on the 3rd of March. And then looking at issues around the data, the ratings, and our CQC register. So we've got a range of long-standing issues around data quality and consistency. So that's we absolutely need this information to help us monitor and manage risk. So all of that is being looked at as well. And just in relation to the Care Provider Alliance review, we very much welcome this report. We proactively asked for the Care Provider Alliance to do the review with a focus on adult social care. And it's been really helpful and instrumental in ensuring that we hear the voices from a wide range of adult social care providers, as the findings are robust and a real good reflection of providers' views and experience. And I think, I just want to say that we acknowledge the strength of feeling from providers about the need to improve their experience of inspections. And we acknowledge the detrimental impact that our new approach has had on providers and their staff, including on wellbeing as well. Absolutely, this, of course, wasn't what we wanted. We wanted it to be a much slicker and improved process, but sadly, that wasn't to be. So, as I said, a lot of work is taking place to rapidly improve this as well. So we will now work on the 11 recommendations with this in the CPA report in more detail and consider their implementation. And obviously some of those recommendations will be subject to further discussion, policy change or consultation as well. And it's really important to consider the CPA report's recommendations in the context of everything else that we're trying to improve and develop as well. So, like I said, we are absolutely, determined to improve providers' experience of regulation, to get back, to the point we were before we implemented the new systems of being the really credible regulator we knew that we needed to improve, and at that point. But like I said, the improvements that we'd had hoped with the single assessment framework and new technology hasn't worked out as it needs to. So we're absolutely putting all of our energies into making those rapid improvements. I'm really good that we're going to be strengthening our sector leadership and senior leadership within CQC as well, and that we've got out to recruitment for those key and very important roles. Okay, so that's the key update that I wanted to give, really, just in terms of where we are as an organisation and our plans to make improvements. So I hope that has been helpful. And is there any comments or questions? I'm very happy to have a discussion.
Thank you very much for that, Rob. I think there's a lot there to everyone to digest.
There is.
There were various questions, and obviously on various levels. I think there's some obviously senior level, as you've mentioned, with the changes at the top, but there's also, I think, a lot of the providers are seeing how it affects them immediately as well now. So I think there'll be a range. I'm not sure what you can answer. I'm sure you'll do your best.
Yeah, sure.
So if anyone would like to start with a question, I think Rob is open for those who want to actually come up, put their hands up, as I said, to answer a question, or there's the chat. So we can take it from there. So there's a question here, so I'll start the ball rolling. You've seen it in the group here. Are we going to have our own inspectors? So I'm not sure what you mean by that, but Rob, I'm not sure if you can work.
I think I know what is meant by that. So previously, before we moved into the new ways of working, for every location that was registered with CQC, we had an allocated relationship lead, so a named inspector who would work with that service, and that's changed. With the new ways of working. I'm actually leading a project and a pilot on this for all of the different sectors, and that has been running since September last year. So we've in the London and East, which is my network, we've been leading on the adult social care pilot. The North has been doing the NHS, Midlands has been doing independent health, and the South primary and community care. So we are looking at different models that we could have, but the key thing is, and I have to be really open and honest with you, is that since we moved into the new ways of working, we were hoping that the new single assessment framework and the new technology, like all public service organisations, we need to have made reductions in our staffing, so we actually have less inspectors than we had previously. So we won't be able to go back to the same model, but we need to look at something that will work as well. So we are, like I said, we're doing that pilot at the moment, and and we will have the evaluation of it done by the end of March. So we'll be able to, following that, it'll take us some time to look at different options and models, and hopefully at some point we will get more resources into operations, into CQC operations, to improve the relationship we have. But we absolutely know it hasn't been working, and you know, with the change, but we need to do something different. So it is absolutely on our radar to be looked at.
I think there are some questions in the chat, but we've got a few hands up. So I think the first question was from Mick Feather, and then Zenat, and then Natombi.
Hi, Rob.
Hi, Mick.
I think really there's one in the chat as well, which I'm trying to answer Suk's question as well at the same time. I'm hoping you can answer it. So, and I know there's a lot going on, and I know that, you know, there's a lot of things that are a mess and you've got to sort it all out. But just going forward, the bit that's of interest to me for obviously providers and about what's actually going to, you know, happen now, because obviously there's a massive backlog in terms of inspections.
Yeah.
And I saw it on kind of like, I think there was a London like provider engagement thing, and Newcastle one wasn't there to try and get people, you know, kind of like involved. And that's all great, whatever. But, you know, clock's ticking, inspections need to be done. And I'm sure I saw something about dropping scoring. So is it the fact that scoring will no longer be a thing? Are they getting rid of that and going back to the old days, which is you produce a guide, which is what good looks like, and then I go out and I do an inspection, and it's based on, you know, what I can see and what's there, rather than, you know, quality statement's not a problem, just changing those from Chloe's, but the whole scoring system made it such a cumbersome thing. And the fact of not going out and doing the right amount of quality statements made it a pointless load of nonsense. So is it the fact that they're just going to abandon scoring and go back to I'm going to go out, I've still got the 5 key questions, I'm going to see what the rating is and what that looks like based on a provider guide, which is what you had when you had Chloe's, rather than this, well, I'll score that, and I won't score that, so I'll leave safeguard. Do you know what I mean? Is it a definite, we're not going to do scoring anymore? Because you sort of hinted at that earlier when you mentioned about the fact of doing some sort of hybrid approach, which again seems quite confusing, because providers just want to know, what on earth am I going to be inspected against?
Sure. No, really good questions. Thank you, Mick. So the hybrid approach is where we're doing the inspections both on and off the system. So we're trying to do less things on the system, which means that we can get the throughput of inspections done. So that's not actually about the methodology and the scoring and that type of stuff. That's about how we can get the throughput of inspections done. So sorry, I should have explained that, because it, you know, because I'm just talking about this all the time. I just assume people know, but obviously, you know, it's I shouldn't have made that assumption. But we are absolutely looking at the scoring, as you've said. You know, we do need to simplify this. We do need to streamline it. We do need to look at, you know, inspectors being able to use their professional judgments. So there's a lot of work happening at the moment, and hopefully we'll be in a position soon where we'll be able to say what we need to do. So I can't say at the moment, because those decisions are being made.
But in the old days, Rob, it used to be just that. So in terms of an inspector would go out and say, this is what I think. Here's the guide showing what outstanding, good, requires improvement, inadequate looks like. I know what it looks like. I triangulate the evidence and I make a decision about what that rating should be, rather than me looking at, you know, separate Chloe's and trying to actually score each one. And
yeah, absolutely. So I can't say, because I don't know, because it still needs to be agreed. But all I can say is it's absolutely being looked at. I agree with you. It needs to be streamlined, and I'm hopeful we'll have a much simpler process in place that will work for you as providers, but also for our inspectors as well.
Okay.
The complication that we have is we have to look at the old ratings and all of the, you know, and that just hasn't worked. So that is all being looked at as well. Mick?
I think before we move on to Zenat, there's a link point to this that came up in some of the questions that we sent over to you, and that's about consistency of inspections and the way that inspectors are coming in, about having the expertise relating to that sector, be it say learning dis or autism or whatever.
Yeah.
And that's, I mean, I don't know any provider, and there are others here. Dudley, for example, might contradict this, but I think everybody wants a strong regulator. They want something that can be respected. because we all appreciate that we need that as a sector.
Yeah.
But I think it's a bit like having, you know, your car MOT done. They should be, I mean, they're timed by the Department for Transport, etc. And you can get a video of most of them. I'm not saying that inspectors should be videos, but we still keep hearing comments about lack of consistency in inspections, and that's something that I think really needs to be addressed.
Yeah. Well, I you know, when I hear that as well from providers, Peter, so, you know, again, and with all of the developments that we're doing, the developing the methodology, you know, making improvements in those areas, that should really help with that as well. I know, because I was looking at it actually a few days ago, but I think it was around about 2018-19. We've done some work with the All Trade Association, CPA, looking at about what to expect from an inspection as well. And I don't know whether that's something I think we need to get back into the place where we're doing more co-production with trade associations, providers, and that's on the, you know, we want to do that as well. And some of these issues can be addressed through that, but I think that perhaps re-looking at some of that work will be really helpful as well.
I think that's a really good
No,
idea.
I think that's, you know, and certainly, you know, wanted to, you know, support this work as well. And I'll be discussing this with James Bullion, who is our current Chief Inspector for Adult Social Care, about how we take this forward, work with co-production. So I think that we really need to be doing, you know, much more of that. And having those better relationships like we used to have, so that we can, you know, involve you and you can influence and help us tackle some of these issues, but also give feedback around, you know, where things aren't perhaps working as well and where we need to improve.
I think one thing that again has come out, and I think providers should be able to work without fear and also contact the regulator without fear or favour. Because some of them are frightened if they put quite a lot of them are frightened if they put their head above the parapet and they raise a comment or a complaint that the regulator is going to pick on them. And when you inspect local authorities, we get the impression people are very loath. I mean, these are the market, as you well know, is made up of SME providers, basically.
It is.
And we've had comments that local authority people have said, well, if you don't do this, we'll report you to CQC.
Right.
And that shouldn't happen. Local authority staff shouldn't be doing that. But then if CQC are, as you are inspecting or overviewing local authorities, then there needs to be some grip, if you like, on what clout that inspection carries with the local authority around, say, commissioning, etc. Because no one's yet raised it, but fees are a key issue, and I would suspect that we've got a lot of providers here who are very worried about the sustainability of their business going forward. That's not a CQC issue, but it affects things like, you know, the quality of care, etc., etc.
It does. So that's again something I can discuss with James and others to think about, because I mean, sometimes local authorities do need to say to providers, well, I will need to report this issue to CQC, but not to do it in a, you know, a threatening way, which seems to be what you're describing, Peter, because obviously they have a duty to work with us and report concerns to ensure the welfare and safety of people. You know, that's their job to do that. Likewise, if we have concerns, we need to report some things to them as well, but not in a way that, oh, you know, it feels like it's underhand or threatening, you know.
I mean, I find that, Peter, I'm gonna jump because there's lots of questions. So I know Zena, you had your hand raised, and then there's some, and we will be getting to some questions in the chat as well. Don't worry. We've got a little time with Rob. So Zena, if you can kindly come on and ask your question, that'd be.
Hello. So my question is that until CQC is figuring out that, you know, they're going to see what the old rate, the way they used to rate previously, and then under the new inspection regime, let's say I'm inspected tomorrow, what should I expect? How will I be rated?
In what sense?
So in a sense, you said that work is being done on the way that, you know, the rating is being changed because the new regime was quite complex and it had to, you know, take into account lots of things. So now we are sort of, I'm not sure whether we are going back to the old regime. So my question is that if I am inspected tomorrow, how will I be assessed as a company?
So it will be how we're doing things currently with our methodology. So we have to follow the methodology that we've got at the time. But what we are doing in it is just making sure that we've got really robust, quality assurance processes in place. So it's being checked so that the rating is, right when it goes out. But we do acknowledge that it, does need to change, and that work is happening, as I've said.
Okay. There are a couple of things that I wanted to check, obviously, in the current environment that we are in. So CQC is relying more and more on staff feedback and service user feedback and feedback from the partners whom we work with.
Yeah.
Now, as a domiciliary care company, my biggest issue is that I'm unable to get feedback from the parties that we work with, which includes the doctors and the DNs. They don't even answer our phone calls. So for us to get feedback from them, how we work with them, is just next to impossible. That is one of the biggest constraints that I have as a domiciliary care provider, that they just don't answer. If I get one feedback from one OT in a year, that will not be sufficient for CQC.
Yeah.
But as you know, the GPs and district nurses and social workers, they are so busy that they don't even answer phone calls. So how would they write reviews? That is one issue that I have, and I'm really sort of struggling to gauge any sort of feedback from them, which I could put on my file to show to CQC. The other thing is staff morale. Now, staff morale is down the drain at the moment, because obviously as a company, we are letting staff go because there is no work. The national insurance has risen, minimum wage has increased, council is obviously not cooperating. So the staff morale, when CQC talk to them, is going to be really bad. At the end of the day, it's not all about the environment that you work in, it's also about compensation, etc. And people are quite scared that tomorrow it will be me that will be going. So as a provider, and I don't think it's just me, I think it's quite a few providers who are in this situation. So how is CQC going to take that into account? Because as a provider, I'm working my hardest day and night to make sure that I provide quality care. But I think if it comes to feedback, I'm going to really go down on these 2 points. So I don't want to be penalized for something which is something not in my control, unfortunately. So how will CQC look at that?
So thank you for that, because they're really important points for us to consider. So I think in relation to the feedback from other professionals, I think if you can show when we're on the inspection that you've tried to get that feedback, that will be very helpful, because then we will be able to see that you've done it, and it's not within your control. If those other partners aren't providing it to you, despite you having asked for it, then there's nothing you can do about that. But if we can see that there's evidence that you've really tried for that, then I think we can record that in reports and refer to that. And that's certainly something I will take away, because obviously we're doing a lot of work at the moment to look at to developing the guidance, methodology, etc. So that's really important. And I think the important bit that you raised about the pressures and the and that's just the context that you're working in as a provider. And perhaps there's more that we need to do internally. I'll take that away and think about it. I don't want to just give you an answer now and say we'll do X, Y, and Z, because we'll need to think about it. But I think it's really important that as we're refreshing all of this, that we think about and perhaps it links a bit, maybe, I don't know, to the the guidance thing that I mentioned that we've done in 2015 about thinking about the context of inspections as well. So I'll take that away and have a think about it and discuss it with colleagues. I've got a few meetings actually next week on Tuesday and Wednesday that are adult social care focused, and with all the key policy people and stuff, and with James, our chief inspector, and colleagues that work in adult social care and our regulatory leadership people. These are the people that will influence a lot of the, as well as myself, about what goes in the updated guidance. So I think that is a really helpful point for us to take away and think about.
So you'll be providing feedback through LCAS then, I believe.
Absolutely, I'm very happy to come back and give feedback.
Okay.
To give it to
All
people and Dudley for them to feedback. We can perhaps agree that at the end how we do it.
Yeah.
Yeah, sure. Thank you very much.
There is one point here that a very important one that Zinat has raised, and over the many years of working in social care, I've had a lot of interaction, if you like, between, say, social care providers and NHS units, doctors, etc.
Yeah.
And there is unfortunately perhaps a lack of respect from many parts of the NHS, and sometimes particularly doctors and staff working at GP practices for social care providers. And I still hear comments such as, well, social care staff, they're all right, but they're not trained. They're just, not trained at all. And the other one, which drives some of my colleagues mad, is, well, nurses in social care aren't proper nurses, because if they were proper nurses, they'd work in the NHS. I mean, they are proper nurses. They do their CPD, etc., etc. And if we look at bed blocking as an issue, and many of the providers here, I'm sure, deal with NHS units, and they talk or try and talk to discharge officers in hospitals to get placements.
Yeah.
NHS discharge officers, it's probably easier to get a conversation with the Pope,
right,
than it is to get a conversation with some of those discharge officers, and actually getting proper assessments, an agreed assessment, where there's a I've forgotten the name, where there's an agreed assessment process, it works great.
Yes.
Actually, assessments from NHS units are not are sometimes not very good, because looking at low price, can we get away with this? They'll say someone's very nice, all the rest of it, when in fact they're a real problem to deal with. And sometimes just a little bit more respect. And we've had the problem that Zinat raises about getting feedback from doctors, etc., doctors and nurses. That has been the same for pretty much all the 25 or more years I've been in social care and doing surveys, etc. It's not moved on very quickly, I'm afraid.
Yeah, I would add in very quickly. I know there was this influx when we had the ICSs and the ICBs, was to bring all of the elements of health and social care together. But unfortunately, if you do look at that, social care still feel left out if we look at the ICSs and the ICBs. And I'm not sure how you interact with them, Rob, in itself, but it hasn't really worked out as it should have, especially from the point of things information flowing through all the parts.
Right, okay. So a couple of things there. So I think, we need to think about this more widely in CQC, not just for local, not just for adult social care, because obviously we regulate the primary community care, the GPs, the district nurses, the hospitals, etc. So, and part of our assessment methodology, the regulations, is around how all of those partners work with other partners. So how hospitals, GPs work with that social care as well. And one of the key things in our strategy is around system working and how partners are working together. So I think where we know that there's issues that, social care providers are not getting the information despite having asked for it and perhaps asked again, what can we then do to think about that in terms of our regulation for those ones who aren't providing it? So I think we need to be thinking about that as well. And it's about how we then get to know that you've been asking for this information but not getting it as well, and how we can drive improvement, how we can do this through our improvement arm. Is there stuff we can put in our provider bulletins, for example, to also, it's really important to share the feedback, etc. So I think there's more work we can do, and I'll take that away, absolutely. And like I said, I'm always happy to come back and update on, stuff that I've taken away and what we're doing with it, because I think that's really important, not just to hear it, but to feed back to you as well, what we're doing about it. I see that, that's holding me to account as well. And I need to report back what we're doing. So I think that's really important as well. And we can perhaps discuss at the end how we do that.
Okay. Well, thank you very much. I'm going to go to the next question. I'm just going to take one from the actual chat. And this is one which probably would be quite helpful. Georgia mentioned something about even if a provider has an inspection now and receives any rating below good, it feels like it will take a very long time to appeal and allow them the opportunity to change the rating. And in the meantime, it affects contracts and operation of the company. Just another part to that as well. A lot of organizations who have been rated RI or on inadequate in itself, considering how long it's taking just to inspect services, how long will it take for an organization to be able to change their inspection going forward? Because as they said, it affects their contracts, it affects their business. A lot of local authorities are only working if you only rated good or above. And so then this means it affects the viability of a business. As we know, a lot of them are SMEs. And how long will it take potentially for that happens again? I know you may not have the answer directly on time, but what can they do, and what would you suggest?
So a couple of things there, Dudley. I think if providers feel that their inadequate rating, RI rating requires improvement, or the fact that they haven't had a rating because they've been newly registered is impacting on them commercially, and they can show evidence from that from commissioners, then we will look at that and we will always try to get an inspection done as quickly as possible. So speak to your local team about that. But what we would need to do is, be able to, because we get such a lot of requests, is really have that, feedback from those commissioners to say, because of this, we can't commission. So we would always give those priority. And I think we've been quite clear in provider bulletins and other stuff that's come out that we will do that. So please do that, but be able to show the evidence and know that we will need to check with those commissioners as well, so that we can make sure we're targeting the resources in the right area. The issues around if you've had an RI rating or inadequate and challenging and taking a long time, I can't say off the top of my head, what a new time frame will be, but I will take it away that this is an issue for us to consider and look at.
Yeah,
and I think as well, perhaps we need to look at some of our processes as well. And I think the factual accuracy process can be very cumbersome, too much information we receive, and it can take us days to go through some stuff on the information that we receive. So I think on both sides we really need to have a much streamlined process, which will ultimately mean we get more ratings done, and inspections done, and providers getting ratings. So I think there's more for us to do, certainly to streamline a lot of this, and which is that this is a clear clear one of our immediate actions that we're really focused on.
Just another point to that, I know there's a lot around inspection times. There's lots of figures I've seen banding around. I guess the question is, how long, if a service has been inspected, do they have to wait for the next inspection? Because some services haven't been inspected for quite a long time and still waiting. I know you backlog as well. So how will it work in the future? Because everyone is, if I had an inspection 3-4 years ago and having an inspection up till now, why can't it only seems as if there is an issue or concern or someone reports, do you get them? It's the only way to be inspected quickly. So how do you get around that? What's sort of the time frames that people should be thinking about?
That's what's being worked out at the moment, and over the coming months we want to be much clearer with providers, with the public, about what we anticipate we will be able to deliver. Because there's still a lot of stuff to sort out, we don't want to come out with a figure now, because we don't want to give something that's wrong. So I'd rather us take time and work this out, and then be much clearer on this is what we will deliver over the next year. And we really need to be, because of the problems that we've had with the single assessment framework, the technology, we've not been able to meet our special measure guidance like we've had in the past and like we did in the past. So if a service was inadequate, we would come out within 6 months of publication. If there was warning notices, we would be out to check after the compliance date we'd set. If there was other types of notices, we would be checking. And it's not satisfactory that we've not been able to do that. We know that, we've got to improve on this. We absolutely must, but that's all being worked out. And I think we've got to be following what is our published guidance. on getting out, particularly to those risky services as well. But we also need to be doing, I think with the way the single assessment framework has been set up, and this needs to change, is we've done perhaps a lot of inspections, but they've only been small inspections that have not resulted in a change of rating, but we need to change them because they're so old, as you've said. So that's, again, a key area of focus for us. So it's not just about doing an assessment, which will just be like a small part of it that's focused on risk. We need to look at, doing an inspection, and where possible, one that's able to change a rating.
Thank you very much. I think we had a few hands up. I'm not sure if one of them down, I think, or I've got Grace in front of me, but there was a hand up before, but I'm not sure if that person has gone.
Hang on, delete that. That question has now dropped into the chat.
Okay, no problem.
So if we clear the two hands up, and then I'll come back to Toby's question.
Okay, no problem. Okay, so Grace, your hand's up, so you can probably ask the question now. Okay, I'm not sure if Grace is still there. If we can't, if Grace, her hand is up, I think her question in the chat, we'll address that later. And we'll go to the next hand up. And if I get this name wrong, please don't.
Aguilar, hi.
Aguilar, how you doing?
Hi, I'm fine. Very nice to see you. Okay, I actually put my question in the chat box, but I just want to ask this because I unfortunately have to leave the meeting. And my question is that in the past, previously, before single frame work, we were looking at Chloe's, and we were saying that, for example, to meet S1, we should have this type of evidence. So we were gathering evidence. Obviously, we were doing our job. Our frontline are doing a great job, but behind the scene, we were putting all these evidence in boxes, ready for and prepared for CQC inspection in terms of, in line with Chloe's. Then it went to single frame, and there were obviously questions. And again, I created a folder for all those questions, gathering evidence. Now I want to know whether we should fully stop single frame, like class and categories, and go back to S1, S2, S3, and gather evidence and be prepared in that way. Because I know that you're working, and it's great that you're working and making it clear. And I'm sure there is a good job coming out of it. As always, CQC's aim is just to make sure that providers are, carrying out and providing a good service. And we do appreciate greatly your support and your guidance at all times. But it's just that meanwhile, we are not clear, and we can't wait to hear a year later what is the guidance, and then go back and gather evidence, because we're so busy. We need to know now what is the guide in terms of gathering evidence while we are waiting for your work to be completed.
Yeah, no, thank you. And what I would say, until we've got the new guidance come out, just gather it as you are doing now, and then hopefully once the new guidance comes out, and some of this could be subject to a public consultation, which could take time. That's what we have to do as part of our legislation. We have to, for some things, we have to go to a public consultation. That could take some time, so it will be some time before the big wholesale changes are perhaps made. But what we are able to make some changes in the interim, and we will be letting you know what they are. But I would say just do exactly what you're doing now, keep collecting that information, and then when the newer guidance comes out, you can perhaps switch it over, and hopefully that shouldn't be too much of a big task. But I don't want to say, well, I think you should do this, just in case, that doesn't happen, and then I'm giving you wrong advice. So just do what the guidance and methodology is at the moment. But it sounds like you are absolutely doing the right thing. And the quality statements will probably, stay, they'll be streamlined. So the information that you'll be gathering will be really important, because the key thing is, all of this is linked to what the regulations are. So the regulations won't be changing. So just keep doing what you're doing now.
Thank you.
Thank you. Grace.
Yes, I'm here. Hello. I just was sorting out the audio. Yes, I wanted to go back a little bit what Peter said about the lack of recognition of by the NHS nurses, the social care nurses, which doesn't bother me much, because clearly not the NHS is not much familiar how the nursing home is operating and what cases we're looking after and what decision we have to make, not having the doctor to support us around. And obviously, so it's a huge thing, and you have to have a very, very good knowledge of not on particular subject cardiology or so, but everything basically. We as a home, we GSF accredited, so we're providing a lot of end-of-life care, palliative care. We do cooperate with hospices, so you can only imagine how responsible the job is, and making sure as a manager, I'm a nurse as well for already 40 years almost, how skillful and knowledgeable the staff has to be. And then I've got Isaac with me, who is a nurse as well. But what I wanted to ask as well, and what worried me the most in cooperation between the LAs and hospitals as well, the assessments, is not having been able to talk directly to the discharging is one thing, because normally I will talk to the ward, basically they still know better about the patient, but is the assessment, most of the time there are months out of date, 3-4 months when you get in them and you're reading and you have to speak to the ward because you don't know the current condition. And then with the local authorities, assessment is even worse because they are being conducted by people, most of the time from my own experience, not having completely experience or knowledge about medical health of the patient. The social workers, which obviously the assessment is coming to me and I'm discussing, and person with stage 4 glioblastoma is being assessed by the social worker as a residential needs, which I think is as well about the money, because obviously there is a residential care, it costs much, the rate is much lower than the nursing care. But at the end of the day, you can expect that the residents won't be accepted on the current rate, because as a nurses, experienced nurses, myself as well, we know what amount of need, what kind of needs we have to meet. So I will obviously reject the referral, for example, because I will talk to hospital, I will know what is talk to the family very often as well, to establish the needs and how to plan the care for the person, because before I will admit someone, I exactly have my way of dealing with, which is the assessment with the potential resident, then speaking to the team, discussing, are we able to meet their needs, are we suitable placement for the person. But, and then if the person obviously is being rejected by me and many of nursing homes when I'm talking to my colleagues, and then is again staying in hospital, how economic it is, keeping the person. Obviously, I don't see any benefits of it, no economical, no psychological for the person and the family. So we have to think about it. I know the situation for the councils or the ICBs that is really financially, but when you're looking and starting weighing the benefits and the not benefits, it's still like it would be much financially, I think, efficient for the authorities to acknowledge the needs, acknowledge the rate, and then send the person and to the proper environment when they can have a really very person-centered care. When the family is able to spend, especially I'm talking about people with end of life, when the last months or weeks is so important for the good experience for those people. And as you can expect, there are people not necessarily 99 years old, because we have residents with palliative care needs, end-of-life care needs, when they at the age of their 40s, 50s, 60s, when it's very important that the family has a good connection, that they have the wonderful couple of weeks spent together in an environment which is provide the privacy, because in our home, people, they can stay as long as they want with their loved ones. If they require to stay overnight, they can do that. we do a lot, obviously, for those residents, and keeping them in hospital environment, I don't think is fair. And if about costing, I don't think it's cost efficient. I don't think so, because the rate of keeping someone in hospital, it might be huge.
Thank you very much. Go on, Rob. I'm not sure if you can add some points to that.
Yeah, no, thank you, Grace. And, and I agree, you're doing an amazing job, as are you all, in very difficult circumstances and challenges with finances and system working. I think what I would say to you, Grace, is that if you have concerns that it's impacting upon the welfare, the support, the safety of people, then obviously, make that known to whichever agency it is, whether it's the local authority, the hospital, the district nurse team, but also let us know as well, because we regulate them as well. So, report, to us, and you can tell them that you're doing it, but it's about, the reasons why. If you, both of that will be helpful. But if we know about it and we have the information, then we can start building a picture and themes. And it's not only about, tackling it with that particular individual provider, but we can start building the picture. Well, is this common issue across a number of different local authorities, etc., which it is. And I think for these type of issues need to be explored in better co-production events that we are doing, that we will hopefully start to do with yourself as providers, the trade associations, commissioners, other partners, to start exploring these issues, talking about them, to see what we can do across systems and share best practice as well, around how we resolve these issues as well. So no, it's all absolutely important stuff, and we really want to be able to gather this information better as well. So I think this type of stuff, tell us about it so we can deal with it on an individual level. But I think in the co-production meetings that we're doing, these are exactly the type of issues that we need to explore.
Thank you very much. Thank you.
Dudley, I'm with Grace. So if I could just take 2 seconds, I wanted to check in terms of, so Assall, there's been an issue with the education inspection. And I think their inspection is very similar to CQC in terms of single.
Yeah.
And I was just wondering, with this heavy project going on, how are we learning from that? Because you can see that their concern was that a provider or a service is labeled with one label and a snapshot, which unfortunately that's what the inspection is. But they are learning a huge, lessons from there in terms of being able to move away from this single labeling, or even if it will still exist, making it in a way that the public can see the content and what actually is there rather than the label. So what are we learning from that to influence the changes that we are making?
Yeah, no, thank you. Again, another really good question. I know it's something that we are looking at, but ultimately this will be an issue for the Department of Health and Social Care. It's not up to CQC to say, whether we use the ratings or not. Obviously, we can suggest what we need to do, but that is an issue for Department of Health and Social Care. Clearly, the Department of Education have looked at what Ofsted are doing. We're obviously keeping a close eye on that. I know that we will consider that going forward in the longer term, and perhaps this will be something that will be thought about more in the wider consultation that we're going to do, the public consultation that we need to do. So I will feed that back, but I know there have been discussions about it. We work with Ofsted as well. We have discussions with them, and we, as regulators, we meet with different regulators to learn and share best practice. But again, it's something that we will be taking forward, I would suspect, in the public consultation that we're going to be doing, Penny.
Thank you.
Can I just make a quick point here? Over the years of dealing with CQC and various other bodies, often they will ask for comment, or they will send out surveys. Now, I know that time is precious, but I can remember being at a CQC meeting, and they said, we sent this report out, this survey out nationally, and we got something like 12 responses. Now, if you want to change and make co-production with regulators and with local authorities better, then you have to feed information in. And if providers like Grace are prepared to actually comment directly to CQC, that is very useful to CQC, and they will take note of it. So I would appeal to you, when you have the opportunities with surveys, and again, I know you're busy, but
Yeah.
please do complete them. Or if you don't want to make comments directly, then bang the comments into Dudley or myself, because we communicate with CQC, as you obviously know. We are part of the Care Association Alliance, the Care Providers Association, which covers all the care associations, feeds information back, but they cannot make any changes without co-production. That is absolutely vital.
Yes.
Thank you very much. I think we've got a few questions. I know that when Femi, your hand's up, but we're going to probably try and go to another question in the chat. I think we've got.
Can I just sort out this? And Tomby, sorry, you had your hand up for ages and you gave up the will, lost the will. And you've put your point in the chat.
Yeah.
Do you want to come back and ask that question personally, or do you want me to take it out from the chat?
I have a quick question. This is Femi. Do you want me to just go ahead and ask the question?
Okay.
Go on, Femi.
All right, good. Just a quick one. Thanks for this. I know and I'm aware that you're currently sort of looking at new approach to do your inspection, the CQC. And I'm also aware that the CQC is also inspecting the local authority. My question is just all about the quality of care and also about the payment the local authority pay for care. And we generally know that, you know, quality requires good payment. You don't get quality just by paying cheap money. And so I wanted to know that, do you consider during your inspection, or are you considering now with regards to your approach towards inspection about where you find that local authorities are just paying peanuts? You know, you see the payment, you know, cannot really buy good quality work, because the care agencies, they're all responsible to take the responsibility, and they get blamed if there's low quality work. But so do you sort of, will you put it into your consideration, you know, say in assessing, when you do assess the local authority, whether when they do pay, you kind of look at it and see that, are they actually paying enough money to get the good quality work, rather than just, I mean, the local authority, I mean, the agencies are all just held responsible each time there are issues with quality of work, when truly most times it's because of what the local authorities are doing.
Yep. So that is looked at in the local authority assurance assessments that we do. I'm not sure exactly the detail because I don't work in that team, but again, I will feed that back just to say that, you know, in this meeting that, you know, it's been raised a few times now, and how I mean, I know that we do look at it, and this is the type of information that we need to, that will actually be helpful of doing all of the local authority assurance assessments, so that we can pull out this information and see where there's themes and issues for that for our state of care report, because that's, you know, a report that we have to produce for government each year on the state of health and social care in England. And these are things that will, you know, that the government need to listen to and think about where there needs to be change and reform as well. So so it does happen, but I will I mean, perhaps, I don't know whether Peter and Dudley, this could be something that could be a topic on the sort of wider trade association meeting that we have.
Yeah, that would make sense. I mean, I think it would be good to have evidence if the lowest paying local authorities, and they looked at the results of their inspections, it would be good to see the effect and impact on fees and the effect on the quality of service. But I'm sure once you've looked and analysed your data, it probably showed that. But I mean,
I'll speak to Lizzie. So Lizzie's my colleague who works on the agenda for the wider trade association meeting. The Peter and Dudley that you would chair with other TAs and CPA etc. And we'll see if we can get a session on that, so that all the trade associations can hear about it, and then you can feed it back. Does that sound like an approach, Peter, as well?
Yeah, it certainly does. Thanks, Rob. I mean, I know from attending CAA meetings and CQC meetings and CAA board meetings that the fee issue is raised time and time again. You'll have seen, for example, the Home Association. You know, let's not hark back to fair cost of care, but we are seeing local authorities now asking for very detailed costings. And one of the providers actually shared theirs with me recently, and they're actually making a 3% margin which to my way of thinking as a business person is suicide. Anything less than 6% is suicide.
Yeah.
And the local authority think they're overcharging.
Yeah.
And there's no, I mean, they're paying the staff. They used to be a London living wage provider. They no longer are because they can't afford to do that. They have no debt in the business. It's very carefully run. They're learning this. They provide good service. The local authorities want to do business with them, but aren't prepared to pay back to fees again. And you know, they try very hard to keep their staff because their staff are well trained.
Yeah.
It's very, very difficult. And it's you know, companies going bust. And local authorities do seem to be the, if you like, the fulcrum, the pivot around which all these issues revolve.
Yeah, absolutely.
And just to add to that, Rob, due to obviously being in London, you can imagine you walk across the street, you know, and borough by borough, every sort of fees are different. So London is probably more unique than other parts of the country because there's in that small space, you've got so many different fees and different
commissioners and
commissioners.
You've got 32 local authorities, you've got all the different ICSs, ICBs, the different health commissioners. So
exactly
in a small geographical area.
And you've got local authorities now trying to force providers to use direct payments because they pay less for direct payments, and getting reassessments done on DPs is more difficult.
Yeah.
And then nobody in that sense seems to check up. I'll just go back to Natombi because she did raise the question, and I was going to ask about co-production relating to all these proposed changes. Have all the parties, such as providers, hospitals, clients, been involved in the pilot? It would appear that the balance of power is unfavorably skewed against the providers, despite providers being the ones that are the most dictated upon and with very limited resources. Some of that is actually being covered already, but it does come back to the very limited resources. And if you like, it's the social care is the bottom of the heap and gets the worst of everything and the least of pretty much everything, I think.
And, you know, as an organisation, we're very committed, you know, the adult social care is equally as important as health. Absolutely. We have our regulatory leadership colleagues, Stefan, Mary Cridge, Amanda Pod, you know, who are absolutely, as us as network directors and other colleagues, absolutely, you know, always pushing for parity of esteem of adult social care. But I think the, you know, better co-production and more engagement with providers going forward, you know, will really only help to improve that as well. And actually bring in providers together, you know, not all working in isolation. You know, when we think about the care people have, you can't just focus on one part of their life. You know, we need to think about pathways. You know, there's some health commission, you know, health organisations that offer up social care services. So it's, you know, the health services are commissioned and set up now is very different as well. So we do need to really you know, work with you as adult social care providers, but also in a space where there's other partners as well, because that will help make those improvements and raise the profile by raising your voice with those other health stakeholders as well.
I think before COVID, we had a couple of meetings, one, for example, in Croydon, where the providers turned up, CQC were there, the local authority were there, and someone from the hospital was there as well. And it was a very useful learning experience all around.
I mean, this is just brilliant to me, just listening to all of these issues that you're raising, because it's fantastic stuff for me to be taken away to my colleagues to say this is what we need to be doing, you know, and this is what providers need, this is what they're telling us they want. And this is the only way that we will make improvements is by doing X, Y, and Z. So this feedback is really super helpful. So thanks.
I mean, just to add a point to that, I think this is a great meeting, and thanks for turning up, Rob, because I think there was I mean, I'm sure people know there has been a big disconnect between CQC and providers, and it was always us against them. And actually, you coming here and being a face that people can relate to is one thing. I think part two is that a lot of people used to know their local inspectors, they had a relationship, an understanding of the service. And so it wasn't as if this has happened, it's a shock horror, and you clearly see this wasn't the norm, and there was some form of, and I think going forward, and this is me personally speaking to you from CQC's point of view, I'm not here to do your comms and your charming PR work, but I think there is actually coming here to relate to the people, because they actually want to see that CQC is, I wouldn't say human, but exists. They listen to them. It's not just a case of they just inspected and that's it, and they're not seen again for X amount of years. So having more events like this, and we're gonna try and hold you to at least doing probably something in person maybe, but before the end of the year would be great, because it helps bridge the gap in relationships, and you can see from the voices of what the major issues are, concerns are, and take it back rather than just trying to see the general overview of the country.
Absolutely. Well, I will give a commitment to come to a face-to-face meeting. Just let me know the dates as soon as you can. Like yourselves, my diary gets booked up, months in advance, like yours all will on the this meeting as well. So as soon as I know the dates, it's more chance of me getting there. But like I said, I'm very happy to come along, in a couple of months, and say, well, we told you on the 26th of February, X, Y, and Z, what's happening with that, and I will give an update.
Okay, thank you. Thank you. I think there's one.
I want to do that because it's it's like I said, it's really helpful for us. We need to be speaking to you. We need to work with you. You're experiencing CQC. You know where improvements need to be made, and we're really want to improve and get back really, because we had really good systems in place a few years ago. And I don't think it's that hard to get them back up and running, if I'm honest.
I think if we can just get this one last question, then we'll wrap up because we're moving on. Debbie from Bluebird Care said we have a lot of issues with people not wanting to come out of hospital or accept care due to the fact that they need to pay for their care themselves. Individuals say they want and need but can't afford it. And I know it's a wider issue, but it is impacting the process. And I guess there's a bit of public education, because I've had people ring me complaining about how a residential home wants to charge them £900 a week, which is appalling, to look after their mother. And I'm thinking, hang on, you go into a Premier Inn, it's going to cost you £110 a night.
Yeah.
Including breakfast.
Yeah.
And we know that people are confused about what the NHS pays for and why social care is not free in that sense.
Yeah.
Go on,
so and what does that mean for us at CQC? How can we help with this?
I think it's about information. It's about getting information into the public domain. CQC, as with say the DH, have PR departments, media departments, and we tend to see bad news rather than good news about
yeah.
And I think there are more information stories that can be put out, and people need to be persuaded to come out of hospital, because it's costing us. I don't know what the cost of an average bed in hospital is now. You get various figures quoted, £400 or £500 a night. That's something that if people don't need that bed, they shouldn't really be allowed to sit in that bed.
Right. Okay. No, I get that now. That's helpful.
There was just a few things I wanted to add as a roundup. I mean, there was a question there about, are you seeing an increase in people returning their CQC registrations of late? And has it increased or decreased? Voluntary...
I don't know the numbers of that off the top of my head, but again, happy to feed that back in the next meeting.
Okay, no problem. And so a point I'd like to make, Rob, a lot of people who run services, and you mentioned earlier about what can we expect from an inspection is really important, so people aren't sure. I know a lot of work that we do when we support providers, everyone wants to be outstanding. How to get the road to outstanding is always. But I also feel as well, when people have inspections across the Chloes or various elements, there may be one area which they may not be good at, which maybe puts them in the category of maybe requires improvement or inadequate. And a lot of those providers work to improve on that area, so they're able then to provide the service, but yet it may take them a long time before their ratings change, and then it affects and impacts their business. Maybe looking forward, if, for example, a service has failed in one of the areas and categories and can show proof that they've improved in some form of way, can that be noted? So it may not, for example, change their rating as a whole, but at least it shows that they've tackled or looked at that area and they've met the standards going forward, and then the full inspection can be done going forward, because then that would at least help, because a lot of when patient service users look at services, they'll look at the rate, they'll look at the CQC rating, and if that was then added in, that what area which there was an issue or concern with was changed, maybe then the service may be taken on by the public member. So there's that as well. So I mean, I'm happy to sit down and Peter and I to sort of look at things that can help across the board of what might be good. We also know as well, so that it's important for us also to give feedback as a whole. So maybe some form of platform which allows the providers to share their information. We can share information today and send you the chat as well, and that might be helpful for you to look at when you're going to your future meetings.
Well, what I've got is, I mean, that just on that point, I mean, that was the whole point of the single assessment framework, really, that should be quicker and easier and, you know, be able to do that type of stuff. So those elements we want to keep. You know, so that we can, if it's RI and we got the evidence, and you know, we can change ratings more quickly than we done previously. You know, that it was the intention of that, and not everything would need to be a physical, you know, on-site inspection. You know, if there was evidence from a partner agency, a local authority commissioner that could back it up, as well as evidence from a provider, we could do stuff remotely as well, and that could potentially change a rating as well, and that's still what we want to do. But I've got a list of here of things to take away. So, so like the local authority using the threat, all the stuff we talked around sort of the morale issues and the context issues because of the difficulties within the sector, FACAC challenge, the single work rating, all the co-production stuff. So I've got a list of stuff here which I'll be taking to the meetings next week.
Thank you. The common theme, sorry, Rob, in the group here is if you've got a certain rating, how long will it take in order for your rating to change and when you be inspected? It seems to be the main sort of questions that have been asked here.
Well, could I ask if you could, if what day are we today? Say by close of play Monday, because the meeting are up on Tuesday. If you can just send me in bullet points, not loads of detail, just bullet points is always better. What the key themes and issues are on stuff that I've not mentioned, or even on some of the stuff that I've mentioned now, and then that's helpful for me to then take it away. And then when I come back to the meeting, I could, you know, at a future date, I can give an update on those things.
That sounds great. I mean, I'm sure the audience would probably add more points, then we will send that over to you and give you the general themes as well.
Yeah, if you can, but if you can keep it sort of high level without loads of detailing, because that's better to make the point about what things we need to sort out.
No problem.
We'll try and sort out a date for either a return meet or maybe a face-to-face one if we can get the right venue.
Yeah, well, you've got my email. Just get in touch with me, and we can. Yeah, we'll get it sorted out. I'm very. You know, yeah, I would look forward to that.
Good, thanks. I think we've probably reached a good point to call a halt, unless there are any last points for Rob. We would thank you very much for coming.
No, thank you all very much. It's been really great, and thank everyone for your contribution. Really good points that you've raised, really helpful, and look forward to speaking with you again at some point in the future, soon, hopefully.
Thanks very much.
Right, I will say bye now then, and see you soon.
Okay, thanks, Rob.
Bye now. Bye.
Thank you, Rob.
Bye.
And I've had a couple of comments that have come through to me during the meeting about people not getting information from us. Now, we use bulk mailers, MailChimp, for example, and sometimes that goes into spam or bulk. So if you aren't getting stuff from us and you think you should be getting stuff from us, then please check your spam or bulk and make sure that you alter the settings so that information we send out, because I've checked a couple of the email addresses during the meeting and the email addresses are there, so it's going to them, but obviously it's a problem at the other end. And we, Dudley and myself, will go through all the chat, etc., and some other points about CQC which have been made to us. We will turn them into those bullet points and get them to Rob by that time. And we're part of the Care Association Alliance. We have had a number of conversations already about fees from local authorities and the information not getting through. So I know that there is a meeting tomorrow at CQC, a face-to-face meeting, which I would attend, but I'm otherwise engaged. But my colleagues will be raising the issue of fees yet again, because CQC seem to have cottoned on that they do need to take note of fees. And we also ask you to let us know in confidence what fees you're being paid by local authorities, and we get very little feedback. So we need that information so that we can take it forward. We're not going to say X gets this amount. We know that local authorities pay different fees to different people. We anonymize it. As I say, we're part of a national body, so we are working to get better fees, but we need data. We need data to be able to go to the body and say, this is happening there and that's happening here. So please let us have that. If you don't want to put it in writing, just give us a bell, etc., etc. Dudley.
Okay, thank you very much, everyone, for joining today. As you can see, there is a lot of flux with CQC at the moment, and looks like things won't be solved overnight. But the most important thing is actually, if you're giving us information, they seem to be listening potentially to some suggestions, and they may not do everything overnight, but it's a good time now while CQC are trying to revamp and assess the practices that they've got in presently. So that's a key factor. So thank you very much for joining today. I would say we'll try and get them into a live session. It'll probably be later in the year. I'll speak to Peter because we get sort of slammed with sort of dates. September would be great, but I'm not sure how that would work. But and we would let you know venue, location, where that's going to happen in advance. Other than that, Peter, I think that we've got a few other events that we're running, because obviously it's not just about CQC, it's your day-to-day things. We're doing, as I said earlier, a live inspection in regards to international recruitment and UKVI. Peter's, have you put that in the chat?
I've put two things in the chat. I've put date of the next registered managers meeting, the virtual one as today, is the 26th of March. There's a link in there for Zoom. We have asked DBS, because we've had lots of queries about DBS, if they will come. I'm waiting for a response, and we have a meeting again virtual on March the 5th with a lawyer, and that's around sponsored recruitment. But the key part of that is actually around, if you have an inspection by the Home Office UKVI, how to manage that. And not only is there a lawyer there, there will be providers there who have gone through that inspection, so know how it operates. And my understanding is that a CQC inspection is a doddle compared to an inspection by the Home Office.
Yeah, so it'd be good to join in. You'll see a whole process from start to finish, and you'll be able to ask questions. And we also know that people are also challenging the Home Office and UKVI and some suspensions, and some licenses that have been revoked or suspended, they've actually got them changed as well. So there is a potential to ask that. We also take into account so many things going on, and we can't just cover it in just one session. So if you also as well send either Peter or I a message via email, we will do our best to try and address and bring in some experts or knowledge throughout the meetings. And if we can't do that, we definitely will be able to speak to you potentially between the meetings as well. There is a WhatsApp group, I think we've mentioned before. We share more information on that more on a daily basis that comes through with all the changes that are happening, rather than always on emails. So if you can share it with your colleagues and so forth. I've got some addresses today, and I'll add you to the groups and across the various areas that we work across. Other than that, if there's anyone else who really wants to send any sort of points regarding CQC, please just give your general overview of what you feel that you need to do. Send it to Peter and I, and as we said, we've got to send it by close of play Monday. So if anyone, it would be good to really get it to us over the next day or so. Peter.
Okay, just to add a couple of points. I have had and I have submitted to CQC some points which I'm aware have not been answered. So I will put them back into the bullet point list. And you know, hey ho. And I've just seen someone say they sent their number a long time ago, yet to be added to the group. Is that a WhatsApp group that you wanted to be added to? Because it's one or two of them came through and didn't work. And I'm not saying it was yours, but we had some incorrect numbers put in. So if you just pop it in the chat again, if you would, please, sir.
Yeah.
And we will sort it out.
Can I add to that very quickly, Peter? If you're going to add in your number, what we try and do, we try and put it to areas that you're based in. So if someone's based in, for example, Southwest London, Croydon, Northwest. So if you can put your number and also name and area and organization, it would be helpful rather than me just having a number, because it's just a number with no name, which sometimes doesn't help some of the time. So if you give us probably a bit more information, that would be helpful. Other than that, I will take the number in and probably ring when necessary. Thank you very much.
And Tomby, when you say, does anyone have more information of Providers Alliance, is that the Care Providers Alliance you're referring to? The Care Providers Alliance is a body, I think the present chair is Vic Rayner from the NCF, and many of you will know Vic. It's made up of about 13 organisations, and they are, for example, National Care Forum, National Care Association, the Care Providers Alliance, the Care Association Alliance, which we're part of. That's the largest group in England of care providers. Care England, the Residents Association, and you know, some others, and they meet regularly to put together and present to the DH, etc., points, and they then feed back those points, and everyone tries to spread them down. And one thing that we try and avoid is, if you like, information overload, because there's a huge amount of stuff coming out. We could put more out if need be, but we try and focus on what we think people want. And we rely on people to tell us whether the information that we're putting out is useful or not. So please do. And we try and put links in there so that, frankly, if you want more information, you can follow it through. Dudley and myself, we're neither accountants nor lawyers, but we can put you in touch with people. And we get a lot of information from organisations like Citation, which we send on, and they do a fantastic job of loads and loads of free events, free information. And there are other free events out there that we try and circulate, and also use things like Skills for Care. So let us know what you want. We will try and do it. But do give us a bit of time, because this is actually a part-time job for Dudley and myself.
Just to add in very quickly with the WhatsApp, listen, the WhatsApp groups are there to support each other. I mean, one thing I'd say, respect the WhatsApp groups. You can post information related to sort of care in there. I mean, I've had some very interesting messages in there. Part as well is that you have your colleagues in there, so you can ask questions in there, and other colleagues can also answer questions there. So it's also not just for me to or Peter and I just to dictate or how things are. You can put in information there. There's support there you may get from your colleagues who have experienced various things as well. So it's also a sort of support network within a support network. So do also utilize that as well. So it can be helpful, and a lot of people have really experienced some good information on there as well. So that would add into that as well. Other than that, Peter, I think apart from what's going on a day-to-day basis, by all means, everyone, please have a great remaining rest of the month. Not long left, and then we're going to go into March. So take into account all the things taking place going on, and Peter and I will just keep you up to date as much as possible where we can.
Okay, and I see Mick's got his hand up, so we'll bring Mick in a minute. I've just put a link to Social Works. If you want information about the training funding, LDSS, then pick up that email, that web address, and just contact Social Works, because they're very good. Okay, thanks, Mick. Any last points from anybody, or we will let you return to your work and no doubt a well-earned coffee. Other drinks are available for Dudley.
Thank
Okay.
you very much. This was very useful.
Good, good. Well, you're all very welcome, and we look forward to seeing you next month, and we will be in contact in the interim. Okay. Thanks for now. Bye, everybody.
Thank you very much.
Bye.
Thank you. Bye-bye.
Bye.